Hi, everyone. Thank you so much for joining us here. I'm Yoetzet Halacha and Fertility Counselor Laurie Novick. This is Dr. Rhonda Adessky, and this is Dr. Jordana Hyman. And we are delighted to be here to be presenting about the fertility journey, in particular diagnosis. We have two goals for today's session. Number one, we want to give you a lot of information about diagnosing infertility from a halachic, a medical, and psychological perspective. Number two, we're looking to model an interdisciplinary holistic approach to these issues, and that's an approach that we really took in our training as Yoetzet Halacha fertility counselors. Okay, so without further ado, I want to get started with our first part. Our first unit is really about before diagnosis happens, figuring out when you need to get help and what you need help for. And we're going to do this by asking kind of like a sample question. Okay, so here goes. I'm a 32-year-old woman and have been married for 4 months. We still aren't pregnant, and I'm getting very stressed out about it. What test should I be doing? Okay.
So I see this quite often actually in my practice, couples that pretty soon after they get married are running in and asking for tests. So my general answer is at this age, unless there's any history of problems, nothing. There are no tests that need to be done. The definition of infertility is a year of unprotected intercourse and not achieving a pregnancy. And so our general approach would be wait for a year of the couple trying spontaneously and then coming for assessment, unless the woman is over 35, and our woman isn't, or there are other known obvious factors like known polycystic ovaries, known endometriosis, or some sort of cancer in the past of either of the partners. And as I'd like to show in the slide, the reason that we wait a year, slide one, the reason that we wait a year is because after a year of trying, we see that 85% of couples who are attempting to attain pregnancy will actually get pregnant spontaneously. The next year of waiting will only help the next 8%. So really that's the cutoff at which we recommend coming for assessment, that 1 year cutoff. So we also have, we separate primary and secondary infertility. So primary infertility is couples that have never been pregnant before, which would be like this couple that you mentioned. Secondary infertility are couples that have already had a pregnancy, whether that pregnancy ended in a live birth or a miscarriage or an ectopic pregnancy. And I'll just briefly touch on what we're testing if we are testing. So for this couple, the answer is probably nothing, but just to give a general overview of what we're looking for. Next slide, please. So for fertility, for the creation of an embryo and a successful pregnancy, we basically need the production of an egg from the woman, a sperm from the man, and we need them to meet. So we need patent uterus and tubes for them to be able to meet each other. So the general assessment of fertility will involve checking the hormones of both partners, checking that egg and sperm are being produced by both of them, and checking that the uterus is capable of holding a pregnancy and that the fallopian tubes are patent and the egg is able to meet the sperm.
Can you define patent?
Patent as in open, and that there's passage through the tubes, that they're not blocked. So that would be the basic concepts of what we'd be testing for.
Okay, so that's what you test for when it needs to be testing. You know, there's also a halachic discussion about when you start testing. There's a Talmudic passage, you might be familiar with it, where it talks about, if a couple's been married for 10 years, right, then maybe there needs to be divorce, and that's building on the story of Abraham, and, at what point in his marriage with Sarai, they brought Hagar into the picture.
Right.
And then over the centuries, there have been different discussions among halachic authorities about how long should a couple really wait before they start really looking into what be going on. So a lot of this is more recent than over the centuries. And different years have been suggested. It could be, is it 10 years? Is it shorter? Now we've really gotten to a point where halacha at this stage is really following the basic medical knowledge, because halacha is constantly in dialogue with medical knowledge. So we would go by guiding a couple. We would go by what you as a physician would suggest to them. What are some of the psychological aspects involved in figuring out when to pursue diagnosis?
Well, I mean, that is a huge topic. Obviously, as Laurie said, one of the goals that we would like to do is I want to give you a taste of what the women, the Yoetzet, learn in their course and how to identify what a woman is going through and when she either needs psychological counseling or what the woman can receive from the Yoetzet. So that's what I'm going to kind of demonstrate a little bit tonight. Basically, we know, like the question says, the woman is extremely stressed. Makes perfect sense, right? Obviously, stress and fertility challenges are intimately connected. Stress is defined as a state of mental or emotional strain or tension resulting from adverse or very demanding circumstances. Wanting to be pregnant, not being able to get pregnant, whether it's 4 months, whether it's 2 years, is extremely stressful and challenging. Reproduction, as we know, is a basic human need, and certainly in the Jewish world, it's like the most important thing is to have children. And so when a couple cannot get pregnant, it's very, very stressful. And so often the woman not only experiences a lot of negative emotions in addition to stress, depression, distress, anxiety, worry, sadness, fear, grief. There can be a lot of problems within the couple. Their sexual relationship can be affected, the intimacy issues. Women can feel all kinds of self-esteem issues. What's wrong with me? What's wrong with my body? Body image issues. Lots of shame, anger, feelings of failure, and grief and loss. So what we want the Yoetzet to do, which is what you guys do on a daily basis, is really to help these women normalize what they're feeling and to allow them to have a place to talk about what their concerns are. And we feel like the Yoetzet are a perfect, starting point because most people don't seek psychological counseling right at the very beginning. It's considered a stigma. Also in Israel, unfortunately, while we have fantastic medical fertility treatments, our psychological availability of fertility treatments are lacking. And so if a Yoetzet can sort of support the woman in dealing with what her challenges are, whether it's negative thinking and challenging her negative thoughts, whether it's worry and finding some sort of a way to help her contain some of that worry. I'll talk later on a little bit more about some of the interventions that we do. But, as you well know, sitting with a couple, the most important thing is to offer them hope that having a diagnosis is actually a wonderful thing. It can lead to knowing what's going on and then ultimately treatment. So even at the diagnostic stage, it's important to have the support of a counselor. One thing we know is that it's not the stress that interferes with the ability to get pregnant, but rather Ali Domar, she's a researcher in Harvard, has found that women who are clinically depressed are less likely to get pregnant. So another big thing that we want the Yoetzet to be able to identify and potentially treat, if it's a mild depression, is the depression. Because the research shows that if women who are undergoing fertility treatments also have treatment, psychological treatment for depression, then they're more likely to get pregnant. So we definitely want the Yoetzet to be able to know how to assess clinical depression and where to refer if necessary for any kind of mental illness, which is very important.
So what's so interesting is that when you were talking about the medical picture, on the one hand you're talking about what's necessary to conceive, and the other hand is kind of like a firm timeline. And a lot of the halachic discussion is also talking about a timeline. But when you're talking about the psychological elements, there's no firm timeline of that. That's why really, this woman comes to us and she says, should I get diagnosed? So on the one hand, medically, I mean, we can still find out if there's some other condition.
Yeah.
Like you were saying, it might be, but there's a good chance that she should hold off on getting diagnosed. And yet, there's a place here really for us to support her psychologically.
Absolutely.
Even if she's well before the stage at which she might be diagnosed, and that's what can help prevent the depression that we're talking about.
Yeah.
Even, I would say, the reassurance that what she's going through is healthy and normal, and that it's likely that they won't have problems conceiving, and that this is normal not to have got pregnant yet after 4 months, and it doesn't indicate a problem. Sometimes just hearing that can be very helpful to the couple to know that there's not necessarily a problem.
And also it's normal that she's
That
feeling
she's
stress
feeling,
and worry.
exactly.
And there's ways to help her
Yeah.
bring down that stress and worry, and
Yeah.
certainly, help her have hope.
Yeah. It's also an opportunity, honestly, you were talking about, you need the sperm and you need the egg and they have to meet. It's an opportunity for us also to check in about the efficacy of their sexual intercourse and what's happening for them, which can also, and you were saying there's an interaction between what's going on for the couple and what's happening in the bedroom, but there's also an interaction, obviously, about what's happening in the bedroom and what the chances are going to be to conceive and the emotional temperature for them.
Yeah.
I want to move forward a little bit
Okay.
into, let's get more deeply into the world of diagnosis. Okay, I'm going to give you another case study. All right, here we go. We've been trying to conceive for the last year and a half. I seem to ovulate perfectly. The doctor referred my husband for sperm analysis. He really doesn't want to get tested.
Yeah.
He thinks it's us, sir.
Yeah.
Please advise. All right, this one is pretty loaded. We're going to start with the medical aspect of this, okay?
So in my medical hat, I feel like I'm often using the knowledge I have from the psychological staff and the halachic knowledge, because this comes up all the time when I refer couples for sperm analysis. If it's a couple that are shomer halacha, and even not, they all try to get out of it. This is something that most men do not want to do, and often halacha is a really good shield for that, a really good excuse for, I think it might be asur, and let's put it off. So there are no men jumping to do that sperm test. No one really is wanting to do that. There seems to be a lot of emotional issues, which we'll hear from Rhonda shortly, but usually when I refer for a sperm analysis, I also give some of what I've learned through my teaching. But why is it so important? Why is the doctor referring at this stage? So what we know is that in at least 40 up to 50% of couples, male infertility is part of the fertility story for couples. So if we say that fertility challenges affect 12 to 15% of couples, which is the rough number, about a third of them have a combination of male and female factors, and a third will have male alone, and a third female factors alone. That means at least a third are purely male, and of that other third of combined, there's a combination of male and female. So it's really important for men to have a thorough assessment, which would include a sperm analysis. And doctors may have different approaches, but I send couples for testing concurrently, and I would not recommend invasive testing of the female partner or any sort of hormonal treatment until the man has completed the investigation. So it's really important that that is said from the start. Couples may want to grapple with that and ask a shiloh about it or seek some counselling for it, because it can be quite confronting. But as a physician, it's something that I send for at the beginning of the assessment, and that I see as an integral part of the assessment.
So that's so important, because halachically, I think that if the ideas about it halachically have really shifted over time. And that initially, I think we can take the slide down. Initially, I think the approach in halacha was very widespread approach to just delay as long as possible, or try to get away without doing a semen analysis. But once it becomes clear that the professional standard of care in diagnosing fertility is that the man has to be screened, because just because you found something in the woman doesn't mean it's not something for the men. The halachic rulings have also shifted somewhat. The thing that's the reason why that's important is because the prohibition for a man of hotzat zera levatala or hashchatat zera, of spilling seed or wasting seed, there are different ways to understand it. We already see in the medieval times that Tosfot Rid already says it's specifically when it's being done so as not to have a child. Right? If we think of the biblical example of Aaron Onan, they didn't want to have children. This is a situation, it's not hashchata, it's not wasting seed. We're doing this because we want to have children. It's a different halachic situation. Even so, it's important to note that a lot of Rabbanim will try to hold off the male testing until it's a slightly later stage in the process. It's almost like holding on to that sense of, well, we wait till we have to. The truth of the matter is that Nishmat's Rabbanim, in conjunction with our fertility Beit Midrash that trained the Nishmat Yoetzet Halacha fertility counselors, have come to the conclusion that that's not our halachic policy. And the reason why they've come to a different halachic policy is because if the man really needs to be tested, then it doesn't have to wait. And doing it earlier or raising the issue earlier has the effect of enabling the couple to time that testing in a way that can be important to them. Sometimes time is really the essence of fertility as well.
Right.
And it also sends a really important psychological message to the couple, which I think you'll pick up on, to be saying that both spouses are involved in this diagnostic procedure from the start. You want to pick up on that?
Sure. First of all, it's never his fault, her fault, It's not because she has a problem or he has a problem. It's like we're in this together. And it's incredibly important for the couple to hear that. Because once the blame game comes in, that's when the relationship starts to disintegrate a little bit. And we really want to promote the support of the two members as a unit. So that's really important. And it's also completely understandable why the man is so resistant, whether he's religious, whether he's Jewish, he's not Jewish, like Dr. Hyman said, for any man to kind of be faced with, wow, I might not be fertile. It impinges upon their virility, their manliness. It questions, there are issues of self-esteem that come up, and it's really very, very challenging. And, sometimes the women think, well, it's not such a big deal. And then for them, it's a very big deal. I'm not even talking about religious men. We'll get to that in a little bit. But for even non-religious or non-Jewish men, it's a very big deal. It touches on a very deep insecurity. I mean, the idea that I should just be able to impregnate my wife and I'm not able to, I don't want to know that it's my fault. So that's one big issue. And then the other issue is that they feel very responsible. And they also want children. And if it's my fault, there's something wrong with me that impacts on then how they relate to their wife. And so we want to help the wives also, like that's the role of the Yoetzet, to help the wives support, their husbands in actually getting to do the testing and not delaying, and understand why they are delaying. That makes perfect sense. So having support, having the men learn more about it, and like you said, why it's not actually a sore, is extremely important. And having a place where they can talk about, I think the Yoetzet are less likely to talk with the men on a one-on-one basis, but certainly within the couple, right, exactly. Within the couple, I think it's a really great place for them to be able to support the man, or for them to go to their Rav, if they really feel uncomfortable talking about it to a woman. But I think, the Yoetzet are so knowledgeable both on the medical aspects and the psychological aspects that, it's a perfect place for them to feel comfortable. And if not, there are support groups for men run by men, through Gefen and other places. But it's really crucial that they're understood and, their beliefs and thoughts might be challenged, because it's not really true that they're doing, like you said, they're doing it so that they don't, in order to get pregnant, not just to spill their seed.
I think that what helps some couples is hearing that this is part of their journey of pro-uval, that this is, what the semen sample is, letzorech pro-uval in the bigger picture, even if that sample isn't going to then be used for an insemination or for a procedure, but that the way that seen is part of for pro-uval. It's not levatala. And sometimes just reframing it can help some men that have hesitation, and sometimes understanding that it's not us, or sort of gives some sort of relief and helps them go through with that process.
Is it possible that the semen can be used for
So-
fertilization?
So if we're at a stage where we would consider an insemination, that we can perform a semen analysis and use that sample for an insemination. And some couples request that so that it's really not the vatala, it's actually then used to possibly help get pregnant. But that requires a whole lot of other tests to have been carried out
Before.
and we have to get the timing perfect for it to work. So it's not always appropriate, but it's something that we can try to figure out if that's important to the couple. And sometimes the halachic advice that couples receive is to try to time it like that. And I think some of them psychologically feel better about
Or
it.
it could be frozen. I mean,
It could also be frozen, except that sperm freezing in Israel requires firstly all the serological tests to have been done, and it's not covered by the pot. So the couple would have to pay for that. So it's not always an option for couples at this stage, and they may not need to use it ever in the future.
And we don't want to give them the sense that they have to, that has to be.
I think that when we frame it as part of the process of parole, it gives it some sort of framework that makes couples feel a little more comfortable with it.
You know, it's interesting because you were saying that sometimes you feel like the couple, like they're bringing up halacha, the man might sometimes be bringing up halacha as a way to already short circuit what's very uncomfortable for him, also emotionally, not only halachically. But on some level, when we're responding to this couple, we can use discussing the halacha as an opening to bring them back in emotionally.
Correct.
Right.
Absolutely.
So it's a real opportunity. You know, could we start talking a little bit about what this testing process is? Like,
Sure, sure.
I mean, because one step's going to be talking to them, they're in it together and getting
Okay.
these messages across, but we also need to explain what's happening.
Okay, so I mean, the semen analysis is the big test, but part of assessing the male partner there are other aspects as well. So firstly, with both partners, we perform a hormonal analysis. So we're testing not only the sex hormones, which are in charge of the production of sperm or eggs in the female partner. We're also checking the thyroid hormone, prolactin hormone, testosterone in the male to make sure the levels are normal at male. So give us a little hint if there's a problem with libido or sexual function. So we do a hormonal analysis as well. We're not, the sperm analysis isn't the only test. So we'd be doing a hormonal analysis, checking for any sexually transmitted diseases or any other viruses that may affect the sperm quality or quantity or production at all. We also, I mean, both couples have a full history and also physical examination. So, on the history, we were alluding before to the first couple that may actually have some sexual function issues and just making sure that what's happening in the bedroom is actually happening. So, the first part, we're going back a little bit now, but before we get to the sperm analysis, we've already talked about any problems with sexual function, and that's really important as well as part of the history, any past medical illnesses, any medications, any history of illness in the family. So all of that's actually an important part of the assessment of the male partner, as well as the physical examination. Then we have the hormonal analysis to make sure that the hormones that are related to sperm production are balanced and that there is a hormonal imbalance. Also, some men, depending on what we've found, might be referred to a urologist for an exam and for an ultrasound, a testicular ultrasound, to make sure there's nothing else going on anatomically. And then the sperm analysis is the test that causes the most issues here, as we've been discussing. What do we test with the sperm analysis? So the sperm analysis looks at several parameters. The main things that we're looking at, there are three main parameters. We're looking at the volume, but the main things that we're looking at are the concentration and the motility, so the percentage of sperm that are actually swimmers, and the morphology, which means what percentage of the sperm are actually normal forms. As we can see, we need only a very low level. We need 4% and up to be normal forms. But generally, we're looking at in the millions of sperm and wanting there to be at least half of them swimming or with good motility. I will mention that when we have a semen analysis where the numbers are low, we'll always recommend to repeat that after 6 weeks to clarify or verify that that's the result. Because sometimes a virus or something else that's going on may affect the numbers.
COVID, right?
COVID, definitely. We've seen a lot of changes. I had a couple that I thought were going to have to go straight to IVF after the semen analysis because it was terrible. And I sat with them and then I said, have you had COVID recently? And they're like, oh yeah. I mean, we repeated the analysis 6 weeks later and has since, we didn't send them to IVF, they've had inseminations, it bounced right back. So we are seeing a temporary dip with men who've had COVID. We're not seeing the same thing in women, so it's something that we're seeing in men, but any virus, any sort of flu or virus can actually affect sperm production. So we'll always do a repeat sperm analysis. I've had couples that I've thought are going to need donor sperm, like numbers were terrible, and then the repeat test seems fine. So when I sit with a couple and explain the results, if the results are very poor, I always say that we're going to, I explain that we're going to repeat the analysis and see if that's actually a true analysis. Of course, a lot of couples that come to see me have already Googled and got themselves into quite a frazzle. But that's for all of us. Google is not necessarily the best doctor, but really they're the aspects that we're looking at when we're testing the male partner.
So, halachically, it's not so simple either. For a long time, there was a halachic, a lot of halachic authorities preferred that after relations, they would collect the semen. And they found that this wasn't as effective a method as other methods. So sometimes it's still recommended in certain quarters. On the whole, the approach that the Rabbanim and Nishmat works with have taken is that there are really two primary options for collecting semen for analysis. One is to have relations using a special condom. Some people call it a halachic condom, but it's really a misnomer.
Yeah.
It's just it's a sterile, it's non-lubricated condom. There are some halachic authorities who say there needs to be like a pinprick in this condom, because according to some authorities, the theoretical possibility that maybe a sperm could pass through that hole improves the halachic situation of having used a condom for relations, but that's not necessarily it's not universally held. So again, Nishmat's Rabbanim don't think that there's an obligation to have a prick in the condom, and actually sometimes
a regular condom.
It can't be a regular condom. It has to be a semen collection condom. You get these on Amazon, right?
Right. It can't be a regular one because regular condoms have spermicide as part of their because it's meant to be contraception, so it also has spermicide. So that's not going to be very useful for us in analysis if we kill them all off. Ouch. So we definitely need a specific condom, but the halachic condom concept, I mean, you can purchase them also via Machon Puah or other places. But you could
Machon Shifra in Israel.
Machon Shifra, you could. There are several places, but you could also get a semen collection condom online, and if required, put the hole in. The couple could do that by themselves. It'll still be effective in collecting the sperm. I think it's important though to note that some couples find moving it from the condom into the collection cup quite awkward. So I've had a few couples with a very low volume because they actually have spilled it because it's very awkward and fumbly. And I mean, we'll talk about it, but also some couples find that method really quite difficult because they've never used a condom before, and that whole concept of a condom is so foreign. And so if we, I saw for them that it's actually very awkward for them to have relations like that.
Right, so we'll come back to that in a second. I want to present the second option and then an observation along the lines of what you were just raising. So the second main option for semen collection halachically would actually entail manual stimulation.
Right.
Now, I mean, there are, just for the record, in cases of great difficulty where this can't be done, there are machines that can stimulate. These are machines that were actually designed for people who are paralyzed, I think.
Right. Spinal injuries.
Yeah, called PBS machines, but really again, the Nishmat's rabbinic experts have said that that's also a legitimate option for collecting semen is through manual stimulation. Now, both of these cases, interesting. Manual stimulation is something that a man in theory could do on his own, but it's also in theory something that the wife could participate with. So one of the questions that comes up in figuring out which of these methods to use is to what extent the couple, both members of the couple want to be involved, and that's complex. The advantage to that is, again, that sense of wearing it together. I think you'll talk about this more psychologically.
Yeah.
But the disadvantage is, do we want this to really feel like a distinct process, or is this part of is this touching on our sexual life? That's really complicated. Second thing that comes up with that, even if they want the woman to be involved, is niddah.
Right.
If a woman's in niddah, she can't be involved.
Right.
So that's another reason why it's nice to know if they're going to do this earlier, so there can be more space for timing it.
Yes.
To give them more options. Sometimes freezing can be an option in helping to, again, you're talking about the complications. Freezing, it's not like an easy thing. It can be an option in timing it, but sometimes for whatever reason, the only option is really going to be stimulation that doesn't involve the wife. In that case, Rav Henkin Zatzal, who was rabbinic supervisor for Yoetzet, one of the co-founders of Yoetzet Halacha, a great posek, my teacher. Rav Henkin actually thought that one thing that he thought would be halachically preferable is that if a man is going to be collecting his semen through manual stimulation, he thought this should be done either wearing like a latex glove or using the non-dominant hand. And he felt that this was just it's like a small halachic step to make it clear that this is not like an exercise in masturbatory pleasure. And halachically, you wouldn't necessarily have to obligate it. In fact, the Rabbanim, even Rav Henkin said this isn't absolutely required, but he presented it as kind of as a preference. And I think that actually is going to tie into what you might have to say, Rhonda, about what this means, what it means for the couple, what it means for them to have, as you were saying, what it means for them to suddenly be having relations using a condom, even if it's for the purpose of procreation, and what it means for him to suddenly be in a position of not just collecting semen, and we're saying it's mutter because but to actually be masturbating, which is a whole other world of halacha as well.
Yeah, and so I think the psychological implications of that are enormous. Religious men grow up from a very young age knowing that it's asur, and they're, once they get married, certainly using a condom is not allowed. And all of a sudden, here they go to the doctor, and the doctor says, okay, we need to collect semen, and it's kind of very shocking and very jarring. How do I do this? And I'm not allowed to do this. And so the psychological shift of being able to then feel comfortable, there's a whole issue of performance anxiety. We know that when men have to perform, their sexual ability to, have an erection, reach orgasm, be able to collect their semen is very challenging. And so there's a lot of psychological steps that they need to go through. In answer to your question about how do they come to a decision whether to do manual stimulation or to use a condom, I think that's really a very individual thing that the couple has to come to together.
I should make a point that there are some halachic authorities. Nishmat's authorities have said that it's really just a choice up to the couple, period.
Okay.
There are some halachic authorities who really will say that if it can possibly be done with the condom, that's preferred.
Yeah.
How is that for the couple to be kind of in that space?
I think that's something that it would be important to talk with the Yoetzet Halacha, fertility counselor, to kind of understand what their concerns are. And you're trained in being able to know help them, guide them through what's their thinking about it, what their concerns are, what their hesitation is in terms of having relations with a condom. But I think it's a very individual kind of decision. In terms of your experience, have you felt like you would guide people in one direction or the other, or you would just kind of allow them to express their concerns and then support them?
I found it very helpful that our Rabbanim allowed the couple to make a choice, really, because, it's also, from a woman's perspective, there are women who really want to be involved, and men who really want their wives involved.
Sure.
And there are women who really, who just sort of feel like, you know what, this one is
It's
yours.
yours.
You know, I've always
So
done
much
this
to
thing
do.
going on, and I don't want to be, it's just, if they don't have the, they feel like they don't have it in them to participate. So it's such an interesting mix, because there are women who really feel like this is an opportunity, you know, it's not the typical way that we would be doing this together, but this is another way that we're doing this together. And then,
For a purpose.
yeah,
You know,
yeah.
there's a big, huge goal involved here. And I think that is, you know, keep your eye on the prize kind of thing. That's important. But I think that's why it's really, you know, essential to know what's going on in the couple as well. Because, you know, if the woman is resentful, as I said earlier, about how much she needs, and we're going to hear a little bit about what the woman has to go through in terms of her testing, and she feels like all he has to do is masturbate, or, you know, what's the big deal? But I think it's important for her to understand that it is a big deal, and that he's avoiding it, you know, and he's pushing it off as much as possible because of, like we said, the issues of self-esteem that can come up, the anxiety, and men tend to are much less likely to talk about their feelings around it. And that's why it's important for, you know, wherever they can get the support from, to be able to talk about it, to learn about it, and to get support around it. And if the Yoetzet, you know, are helpful to the wives to be able to support them, that's a big deal.
What, like, if you were gonna say, like, top 2 tips for a husband to support his wife, getting into diagnosis, which is what we talked about that so far, and like for a wife to support her husband in like going through semen analysis, what are like the most important things the couple can do for each other?
Well, I think, you know, understanding that we're in this together and we have a really big goal. And I want to support you in your process, and I want you to support me in mine, in whatever that looks like. So communicating is essential in understanding. And also, I think, you know, learning techniques, stress reduction techniques, we'll talk about that in a little bit, but really learning how to bring down the intensity of the emotion that comes up around these extremely loaded topics. So support and communication would be my 2 main, for both of them. And to understand, the women to understand how men cope, and men to understand how women cope, because, you know, it's very different. Men tend to, you know, pull back, and women tend to, you know, want to talk about it all the time. And just because he doesn't want to talk about it doesn't mean that he's not interested. It doesn't mean that he doesn't care. It doesn't mean that he doesn't want to get pregnant. It means that he's having a hard time coping. And, you know, can you understand that and support him in that, and vice versa?
So if we go back to kind of the question that was posed,
yeah,
you know, it's not just about saying, you know, it's not us, or, and yeah, you go ahead. It's about really reframing the whole process for them, and creating a space for them for each of them to understand more completely what the other one is going through.
Absolutely.
So they go through this, and how they can work together.
Absolutely.
Wow. All right, are we ready for another question? All right, we're going to talk about women. Let's go.
Okay, women.
Okay, here this one came in. We have 2 beautiful kids, Baruch Hashem. The last one was emergency C-section. Then I used the IUD. I had it removed a year ago, and I'm still not pregnant, so that's your year mark.
Yeah.
I guess 135.
I don't know how long.
Okay,
but
they went through their year, okay? My physician recommends hysterosalpingogram. He's recommending it's a, you'll talk about more about it.
A little bit about it.
Okay, procedure that's going to explain something about the uterus. But I'm worried it'll be painful and disrupt my clean days. So we're not talking about a couple that I mean, let's assume that the man was checked, or he's going to be checked, but whatever, they're at a stage where she's already going in for what we would call like a more invasive diagnostic procedure, not the kind of thing that even those who would say the man should wait for semen collection would wait for. Like at this stage, you know, she's going in for something that's a little more serious, and she wants to get pregnant, and she's scared. So what would you as a physician say to help her through this?
Okay, so.
And can you give some more background in general about women's diagnostic procedures?
Yeah, I think I'll talk a little bit about this case and women's testing in general, and then we'll get to this specific test. So this is a couple with secondary infertility because they've already got 2 kids. And there are 2, I would say, red lights in this woman's history. One that she's had an emergency cesarean, and 2 that she's used an IUD, which can both be risk factors for either blockage or scarring of the tubes. So when we were talking about patency of the tubes to allow the sperm to meet the eggs, both of these could be reasons why the sperm may not be able to reach the egg.
Wait, time out, because I think we might have just incited a panic. Should women be frightened of using an IUD lest it starts scarring?
No.
Okay.
It's not usually a complicated form of contraception, but a couple that presents after both a cesarean section and an IUD, it's an indication to consider testing the tubes because there's always a small risk of scarring of the tubes. And after a cesarean section, there can be adhesions or scarring of the tubes as a result, especially when it's an emergency cesarean section. So in general, when we talk about women's tests, they're kind of divided into non-invasive and invasive tests. This is obviously going to be brief in the interests of time tonight. I could probably give a whole lecture just on testing, but we need to cram it into a few minutes. I will start by saying that even tests that are not non-invasive may be extremely invasive from a woman's perspective. Yeah. So in the non-invasive list, we've got, vaginal ultrasound, we've got breast exam. I consider those to be potentially invasive and difficult for women. But I'll go through basically the tests that we do to assess women, and then we'll try to speak specifically about this test that this couple was referred for. So similar to the man, we start off with a medical history and a full physical examination. The next thing that we want to do is assess the hormones. So again, the sex hormones, the other hormones, so it's possible a thyroid imbalance or a prolactin, the hormone responsible for milk production, or other hormones may be out of balance, and that might be affecting ovulation. So we start off with hormonal testing at the beginning of the period, which is called the follicular phase, day 3 to 5. We also assess with ultrasound. And often do what's called ovulation tracking, which involves a series of blood tests and ultrasounds to try to identify if and when ovulation is occurring, and if there's any hormonal issues surrounding ovulation. And then we might do another hormonal test after ovulation to assess the progesterone production after ovulation, or the luteal phase progesterone. Aside from the tests surrounding ovulation, which, as I've said, are a series of blood tests and ultrasounds, at this stage we also send for several other tests to check the women's basic health before getting pregnant. And that could include a breast exam, which, as I said, is not considered invasive but might be very uncomfortable for some women. Yeah. A pap smear, which some women would consider an invasive test. And women perform, we ask them to update genetic screening tests and also a virus screen. And that would be part of the basic assessment, even though it's not specifically an assessment of fertility, it's a pre-pregnancy assessment to make sure that they're healthy and can get pregnant, that there's no reason to delay pregnancy for any, if there was an abnormal pap smear or an active CMV virus or something else going on. The next level of testing, which is classically the invasive tests, try to assess the uterine cavity. So we might perform what's called a hysteroscopy, which is a little thin scope, a camera that's inserted through the vagina into the uterus to see the uterus from inside and give us an idea if there's any scarring, if there's a septum, if there's a polyp, if there's a reason why implantation might not be occurring. The test that this woman was referred to is a hysterosalpingogram, which is a kind of, it's actually X-ray, so there's some radiation involved, and it's the injection of of fluid that will then show up on a series of x-rays and show us basically the shape of the uterus and the flow through the tubes. So we'll be able to identify if there's a blockage in one or both of the tubes and the shape of the uterus. There's also another option or an alternative to that test, a sonohysterography or a hydrosonography, depending on what country you're in, whatever it's called. But that is a similar test which involves a certain foam or fluid also being injected with thin catheter into the uterus and tubes with an ultrasound image of the passage of that fluid through the tubes. It also gives us an idea if there's any sort of blockage and if there's anything unusual about the shape of the uterus. The timing for those tests is usually during the Nekiim, so it's when a woman is not bleeding anymore and before she resumes relations. So it's right in her Nekiim, and I understand that this woman's asking a question. I receive a lot of questions from patients about to have the tests, about what to do, how to do the dika before not, which day will this, and of course these are couples trying to get pregnant, so they don't want to waste that month, and it's really important to them. So that's the test that we're talking about that this woman was asked to do. And I guess I would include here in the invasive tests what was considered once the gold standard of fertility testing, which is even more invasive and requires anesthesia, and that's laparoscopy, which is a laparoscope camera being inserted usually through the belly button, but into the abdomen and pelvis while the woman is under anesthesia, and that gives us a really good view of the uterus and the tubes. We're also able to inject fluid and see it pass through the tubes. It gives us information around the uterus, helps us identify endometriosis, if there are lesions, things that we can't see on other tests. That, in my mind, is super invasive. That's requiring anesthesia. It's another level of invasive. It doesn't sound like this woman requires that yet, but it's often considered part of the fertility workup for women. So again, I'm sorry that I'm not able to go into a lot of details, but I just wanted to give a context for this couple and this woman and try to explain why maybe she's being asked to undergo this test at this point in her.
Okay, so her HSG is going to be, it's going to be X-raying her uterus and her tubes.
Yeah,
it's going to give us a lot of
X-ray
sense of what's
image,
happening there structurally.
Yeah.
And it involves a dye.
Yes.
And it's not hard to see why one might start panicking if this is happening during our clean days. I mean, you're going in, and not only that, there's this dye there that has a color. I think that, the way you just explain things, I think one of the great transitions in medicine, and I even feel it just in the past few decades, is the sense that physicians are being less paternalistic and they're explaining more things to us. And I think I really see a difference when a woman comes to us with a question and she knows what the procedure is and she understands what she can expect.
Yeah.
And when she doesn't. And halachically, that also really matters. When it's so hard when a woman asks us a question after she's undergone a procedure, because oftentimes there's things that if she had known them before, first of all, she just would have felt more prepared.
Right.
And I think it's also it's important for someone to know what's going on in their body, but halachically she can be more prepared as well. This fear, one of the best ways to combat fear is knowledge, right?
Yeah,
so thank you. So,
right. Knowledge is power.
Knowledge is power. I'll
knowledge
with you on
is
that.
power. Okay, that's all right. Fertility journey diagnosis 1, knowledge is power.
Definitely.
Yeah, and actually that's not a joke, because that's the fear of diagnosis, is I don't want to know.
That's
knowledge is power.
Right.
But coming back to the halachic aspect of this, I think that a lot of times the fear is that you can't get through the clean days, and it's just not true.
Right.
It's really important for women to understand this happens all the time, that women need these procedures during the clean days, and it is not necessarily the case that they can't get through. If you have good guidance, a lot of times you can get through. What do I mean by good guidance? I mean, first of all, just one question that comes up sometimes halachically with medical procedures, especially going into the uterus, is what size instrument is going to be used.
Right.
Because if the uterus is getting opened by a physician beyond a certain point, that can cause a halachic question. Maybe that could be niddah even if there isn't actually bleeding.
Correct.
But we follow the physicians, very widely followed, the physician for Moshe Feinstein. that, you know, if the instrument used is smaller than 19 millimeters, that it's not considered a question in this regard, and that's standard for these procedures.
So both the hysteroscope used for a diagnostic hysteroscopy and for the hysterosalpingogram, any of these procedures, it's between 4 to 8 millimeters tops. We're nowhere near the 19 millimeters. So in terms of opening the cervix or the uterus, I don't think that's a
so
relevant
that's critical
concern.
information for women to know. The procedure itself, and sometimes the procedures can lead to some bleeding.
Correct.
I think it's so helpful when physicians tell women what type of bleeding they might expect after the procedure.
Yeah.
But that bleeding, a bleeding that's caused from the procedure, especially like something's called diatenaculum, like it's being pressed or something, that kind of bleeding is what we call dam maka. Blood from a wound or from trauma, not dam niddah, and dam maka doesn't make a woman niddah.
Right.
And that's critical also for women to know. That being said, it's not, look, the dye also, I should throw that in. So the dye is like a light brown color.
It's a brown because it's got iodine, but it's not red. But yes, some women can get a bit thrown by that brown fluid.
So they need to know what can happen.
They definitely need to know that.
And it's not niddah making, and it's not blood.
I mean, I think the best guidance is that I actually tell women that on the Nishmat website they can download, you know, they can bring the form to their physician, because I'm referring, I'm not usually the person performing the test, but they can bring that form in on the day of their test, and the physician will actually be able to record what instrument was used, if there was blood seen, and that then.
So it's interesting, we don't actually have a form yet, like we have a couple cases where we put up questions to ask, but that's an interesting approach.
Okay, so I say print it up, but and I also say to do a bedika in the morning before the test.
Oh yes, so
and I usually say there's probably going to be some bleeding, and it's usually from the cervix, and ask the physician performing the test, do they see blood and where the blood is from. And I think women knowing that, I mean, this woman's frightened of the bleeding, but knowing before that there might be, and being able to speak to the Yoetzet and have halachic guidance of what to do on that day and how to relate, what questions to ask and how to relate to that afterwards, solves pretty much most of her concerns here.
Yeah, I think the way I phrase the question is not so much did you see blood, it's did you do something that you would expect to lead to bleeding, or that you saw led to bleeding.
Right.
And here's the thing, now we still want to minimize questions, right? So there are a couple other steps that we will generally take when we're guiding a woman before these procedures. One of them is exactly what you said, do your bedika of that day before the procedure.
Right.
Like that has her covered up until the procedure happens. Oftentimes we'll tell a woman to delay performing further bedika until she gets to the 7th day of her clean days.
Right.
Just because we don't need to create the tension, we don't need to create the question. We also can give her body a break a little bit, give her a little space. You know, this is halachic consultations, we're going to have different positions on this, but often she'll be guided, you know, the 7th day bedika is very, very critical. Bedika at intermediate days, and in some situations can be omitted, and this is a situation where often, you know, she's going to do a bedika and she's going to come to the blood from a trauma, from a wound, and she's going to have all kinds of questions, and we don't have to do that.
We don't have to
oftentimes. So that's something she should get guidance about. She should get specific halachic guidance. Different people might tell her different things. She should get specific halachic guidance about what kind of bedika she needs to do following the procedure. And the last thing that we'll usually advise women about in terms of niddah is taking precautions about stains. Now, again, we can attribute bleeding that's consistent with the procedure to the procedure. And at the same time, if we can take halachic steps so that there isn't a question, that's a win.
Right.
So, you know, wearing, it's the clean days, so usually you don't wear colored undergarments. We often will tell women to wear a panty liner. Some rabbanim will say to wear a colored undergarment. That's important because it means that stains on those surfaces could be disregarded. We'll have different guidance depending on a woman's halachic tradition on what she should do in the bathroom in terms of wiping and how to take care. It's just like, it's taking these little steps that are empowering a woman proactively not to be in a situation where she doesn't know what her status is.
Right.
And that's something that we really try to do. And really, so many women, they come into this afraid that they're going to mess up their whole clean days, and they really are going through so much, they don't want to wait. And if we can get to them first with guidance, it usually doesn't have to be that way. They can get to the mikvah on time.
Right.
Okay, but I mean, we haven't talked about, and there's a lot to say. What is she going through?
So, first of all, I just want to comment on the last thing that you said. I think it gives the woman a sense of control and empowerment to be able to feel like she has knowledge, she knows what to do, she knows what to look for, and she has some control over what's going to be in terms of not losing this month, not being able to have relations with her partner and trying to get pregnant. So that is really huge. But in terms of like the psychological impact, there's first of all, obviously, as anyone who goes through medical procedures, it's scary. You know, it's like, what's going to be, and what are they going to find, and what if something gets messed up? You know, they're dealing with the area that I want to have a baby. You know,
we were getting nervous about potential mess ups with the video relay.
Right. So there's a lot of concern, just pain factor, right? And so it's really important to understand what she's concerned about. The other issue that I think is less well known is that, well, first of all, 3 to 4% of the population have blood injury injection phobia. So they're terrified to have any kind of procedure done, whether it's a dental procedure or a vaginal ultrasound. That's frightening. But on top of that, there's more research to show, also out of Israel and out of the States, that women who are going through fertility problems have a higher likelihood of having had sexual abuse in the past. And it's not something that we know a whole lot about, and it's not something that many women want to talk about. But if you think about, that now doctors are coming and, testing them in areas that are so sensitive, emotionally and physically. Yeah. It adds a huge level of stress and anxiety and, the desire to avoid. So I think, it's an area that we need to tread very, very lightly on, but it's something to keep in mind. And as Yoetzet, these are the kinds of things very gently you ask about. You ask about what their concerns are and what they think about it and what they think about having an ultrasound or any other kind of procedure that they have to do. And then, of course, you've been taught all these fabulous techniques, whether it's, stress reduction through breathing to bring down like that adrenaline, hyperventilation, muscle relaxation to help them relax their bodies, as the, ultrasound probe gets closer.
That's what you do with Karen Gefen, right?
We do that, but, you guys have learned some of that, and you
I should just explain, Karen Gefen is the center that Dr. Adessky is clinical psychological supervisor, and Dr. Hyman is the medical supervisor, and they do amazing work, mind-body support separately and together for women facing fertility issues, and they also co-sponsored the training of the Nishmat Yoetzet Halacha fertility counselors. That means that Dr. Adessky and Dr. Hyman were there with us every step of the way, which has been a tremendous, tremendous gift to all of us. I'm sorry for cutting up. Tell us more about that too. I just had to get that in. I mean, people need to know.
Yeah, so we offer groups actually for women and men who are going through fertility challenges. And we teach them all kinds of skills, but also the Yoetzet Halacha have learned all kinds of skills to help women relax their bodies, challenge their thinking, their negative thinking. Oh my God, this is going to be a catastrophe and it's going to be horrible. And to shift that to, well, we don't know, and this actually could be something that is a really good thing, because like you said, if it's just a blockage, then, there's a really easy peasy thing to do about that.
And it's another step towards conceiving our baby. It's another step in this journey, if you will. And we're moving forward. I think that's an important way to frame it as a step forward.
Yeah.
Even if it needs to be a slow step.
Right.
And respecting
the painful step.
But some women will get a referral for this test and will book it in, right? That day they'll phone up and they'll book the test. And some women, that referral is sitting there for a month, for 2 months, for 3 months. Sometimes they come back and I'm like, okay, so you got the results? No, I haven't done it yet.
Right.
So,
and that's the other thing, is the support.
Right.
Like one
Definitely.
thing that we really try and do, one of the things that Karen Gefen also offers is a buddy system.
Yeah.
So either the support from the Yoetzet Halacha, fertility counselors, or the buddy system where you have somebody who's been through this, support them, or, knowing that this is difficult. So who would you like to have join you? Would you like your husband? No, I don't want them there.
Right.
Would you like your mom? Would you like your best friend? And like really holding their hand, or the fertility buddy, do you want us to come with you? So that's a very important piece of helping them feel less anxious about it, is to have the support. So that's,
Well, so I mean, there's so much information that are being, there's so much, I mean, we've only covered some of it in the session. I'm gonna ask you for closing thoughts in a minute, but just thinking back about this couple, there's so much medical and psychological and halachic information that they need to know. But I think what you're getting at is that we have to hear them. I mean, we can't just throw the information at them. We have to really understand what are her concerns about the medical procedure, what are her concerns in general, what is going on for them halachically. Like, we have to.
And the couple, what's going on with the couple?
We have to give them a chance to kind of to take the lead to the extent we have to, akatako, like it says in the statement, like you open it up for them, but then we also have to let them take the lead to the extent that we can. I liked what you said before about, it's another thing I can't control.
Right.
That in the process of supporting the couple, we have to find a way to give them whatever space for control they can have.
I think the whole approach here is that fertility, that we expect to find our partner and marry and have a family. That's what we expect is going to happen. No one expects they're going to have fertility problems. This is already not according to plan. Yeah. And a lot of couples feel this lack of control, that they're not able to control what's meant to be happening and what's happening with their bodies. So part of it is about giving some control back to these couples, and the more guidance and explanations, and some of them do well with having options presented so that they can take some level of control. But there's a fine line there, and you need to find what's right for the couple, because some couples don't want to make any decisions, and some couples really want to be involved in every decision and try to take back some of that control that they feel is being taken away. And I think it's very individual. And sometimes, although we think knowledge is power, sometimes too much information can also be overwhelming. And sometimes the knowledge and the empowerment that we're trying to convey can cause more anxiety and concern. So I think there's a fine line there, and it's very individual. And sometimes both members of the couple are not really on the same page, and that's something I guess Rhonda would also see a lot, that couples going at very different paces from each other. But that's I guess
just zoom ahead, and the
art of listening and hearing where they're at, and providing the guidance and support that's appropriate for them as a couple, because none of us are treating a textbook. We're all treating individual people and couples. So I think that's one of the important messages that's important to convey tonight.
Thank you. Is there a way that you would kind of...
Does we have a question? Okay.
We're going to get to questions in a moment. I want to have some closing thoughts, and then we're going to open it up.
Okay.
Is there kind of like a closing thought that you have for us?
So I think that, when we think about fertility journey and the stress and the potential depression and the potential conflict, it feels like this huge tension that can, like Dr. Hyman was saying, it's so not expected. We never grew up thinking, oh, we'll have difficulty conceiving. And it just throws us for a loop. And so I think having the support, having the backup from wherever it comes from, whether it's from a psychologist, whether it's from a Yoetzet Halacha, there are ways to get through this in a much more easy way. There's lots of techniques to learn to bring down the stress, to help with depression or feelings of overwhelm. And I encourage people all the time, right from the very beginning, even like we were talking about before diagnosis, to just kind of, because there's that anxiety and obsessiveness of, oh my God, I just have to get pregnant, I have to have a baby. And that can be counterproductive in just enjoying life.
Right.
And life happens,
And enjoying the beginning of a marriage. I mean, this couple were newlyweds basically, and so.
And the expectation that, Shana, we have to get pregnant.
Right.
And that's challenging.
Right.
So.
What I love about hearing the two of you talk, and also just talking with you, is that sense of, and this is what I wanted for this session, that sense of like what it means for the physician and the psychologist and a halachic figure to come together and talk about or see the kind of the holistic situation that's there. I think it's so important. We are whole people. When we're getting medical treatment, when we're going through psychological issues, when we have a halachic question, we're still whole people. We're creative and self-moki. This is hitting on stuff that is so primal. And I think one of the most important messages I want to get across tonight is that we want to offer women support that's going to see all of them. We want to offer couples support that's going to see all of them, because you can't compartmentalize all of this stuff out.
Yeah.
You really shouldn't.
Right.
I think I would probably also say that part of that holistic approach is that there's always room for hope and for emunah, and that's part of this whole journey. I mean, I'm supposed to be the medical professional here, and I'm constantly humbled by all sorts of women achieving
Miracles.
Pregnancy. Yeah,
Miracles.
and at the end of the day, science is science, and we can have statistic models to predict success, but we just, there are some things that are not in our hands. And I just want to end with a tiny story that, Sunday's a work day here. So Sunday morning, I arrive to work and everyone's really down and depressed about what's happened at Miron and feeling so flat. And I walked in to start my egg collections, which is what I do first thing Sunday morning. My first thought was, how lucky am I to be walking into something where I am helping create life after this tragedy. Like, I don't know, it helped me get through it. And the first woman that I had, it was like Hashem said this case to me. It was a woman who 2 years ago at age 36 had a sky-high FSH hormone and was told she was probably going to need egg donation, actually referred for egg donation, had a single cycle where there was one follicle seen. In her egg collection then she had 2 eggs collected, 2 fertilizations, 2 embryos put back, and had twins.
Wow.
That, like,
Oh my gosh.
and then on her collection on Sunday, 1 follicle, which I collected, a mature egg, and she's going to have an embryo transfer tomorrow. And I don't know what will be, but these, there are the numbers and the statistics, but there are always cases that surprise us. And I think that couples need to hold on to their emunah and their hope, and while we know to predict some things, we never ever know what is going to be the rest of the journey for a couple. And well, I don't believe in giving false hope, but I don't think that science can answer everything, and I think that that's a really important thing that I'd like to end off with.
Yeah, I think it takes a lot of emunah to get into this diagnostic process, and it takes
Definitely
a lot of emunah to move forward.
Mm-hmm.
Takes a lot of emunah to have a family as well. It's all, yeah.
All right, we're going to take some questions.
Okay.
One question, because we went a little long.
Okay.
2 participants ask about holistic dietary options, naturopathic intervention, in addition to medical treatment for PCOS and ovulation or any other diagnosis. I think we should start with you on this one.
I mean, I think there's another session on treatment where I think polycystic ovarian syndrome will probably be discussed along with the treatments. But I will say that in terms of diagnostics, that when I think that polycystic ovaries may be an issue, my approach is definitely holistic and would include a dietitian, definitely to consider acupuncture, Chinese medicine, naturopathy, and definitely diet and exercise and lifestyle is part of polycystic ovarian syndrome. But I believe this will be touched on later in the second part of fertility journey. So in terms of diagnostics, I don't personally have a lot more to add here, but definitely it's important to look at the whole picture.
And I'll just add that, at Gefen, Karen Gefen, we also offer, in addition to the psychological counseling, we have a reflexologist, we have a naturopath, we have acupuncturist, massage, yoga, because we believe not specifically for PCOS, but for any kind of, fertility issue, a woman can only benefit from feeling better and getting that kind of, support in their bodies. So
I think spiritual support belongs here also. It's not just the prayer. I mean, I know at Gefen they have a learning group where they meet together. Women are meeting together over Torah to talk about their fertility journeys, and I think that, it's part of a holistic perspective. That's also part of what we want to do, and I think it's actually, in my experience, women are sometimes looking for someone to remind them of that a little bit. Like that moment where you say, it does matter that you're davening.
Right.
No,
Right.
nothing.
And I'm not alone in this. Sarah and Hannah and all of these, figures.
Right.
Also.
Which is part of the learning, I think, to connect to all the cases of women and couples in the Tanakh that have grappled with this, and I think it does help people feel less alone.
Yeah, well, thank God. I don't think we're alone. I think we're, Bezrat Hashem, conferences like this and professionals like you and organizations like Nishmat, Gefen, working together, and the other all the other organizations and communities involved in this together. I think we can really be there. We can really be there. We can show up and we can make a difference. Bezrat Hashem, that's what will happen. Thank you so much for joining us here tonight.
Thank you.
It was a real pleasure.